So next we have Dr. Prag, who will talk about robotic versus laparoscopic rectal resection for rectal adenocarcinoma, a nationwide analysis of surgical outcomes.
Very good morning to one and all. I'm Prag. You can call me Prag. My parents didn't know I'd be in the U.S. when they named me. I'm a surgical oncology fellow at Roswell Park Cancer Institute. I'm here to present our study on nationwide analysis of robotic versus laparoscopic rectal resection for rectal adenocarcinoma. No disclosures. As we all know, laparoscopic surgery is a well-accepted, minimally invasive approach for resection of rectal cancers. And robotic surgery obviously has its advantages, such as stereoscopic vision, avoidance of tremor, better precision in dissection, et cetera. And it has been published that robotic surgery is safe and feasible compared to the laparoscopic approach. However, most of these studies are large single-institution studies or being published by select robotic surgeons with high expertise, and we have no idea what it is, the outcomes at the national level. So our intention was to compare nationwide short-term surgical outcomes from minimally invasive rectal cancer resections based on the approach, laparoscopic versus robotic. We used the National Cancer Database, which, for those who are not familiar with it, it's a fantastic cancer database which captures about 70% of all the cancer cases done in this country. Within a 2-year period from 2010 to 11, we chose all biopsy-proven rectal adenocarcinomas, which were done minimally invasively, and excluded any patients who had concomitant colon surgeries. The sample size was 6,478 patients, and we analyzed all outcomes such as age, race, sex, ethnic origin, insurance status, comorbidity index. We also studied tumor characteristics and treatment characteristics such as neoadjuvant therapy and type of surgery. The outcomes analyzed were mostly overall margin status, circumferential resection margin, time to adjuvant therapy, conversion rate, hospital length of stay, readmission rate, and mortality rate. Out of 6,478 patients, 80% of them were done laparoscopically, and about 18% of them were done robotically. And as you can see from this graph, in that time period, there was a downward trend for laparoscopic surgery and an upward trend from 15 to 20% for robotic surgery, and this difference was statistically significant. We then compared the two cohorts to see if there was any selection bias, and we found that the patients who underwent robotic surgery were ever so slightly, but statistically significantly younger, were more likely to be insured or have private insurance, no differences in tumor biology, and were more likely to have undergone neoadjuvant chemotherapy or radiation. There was also differences in the surgery code in which they were captured. These are not CPT codes. These are Commission on Cancer coding system, where anything that's recorded as a Hartman's or an LAR would come under code 30. Anything that would have had a coloanal anastomosis would be coded as 40, and anything that included APR would be coded as 50. And we found that there was a higher proportion of APRs with the robotic group. We did control for these factors in later analysis, as I'll show you later. When we compared the surgical outcomes overall, we found there was no difference between these two groups in laparoscopic or robotic, except for a significantly lower conversion rate, 7 versus 17% with robotic surgery, and a lower mortality rate with robotic surgery of 0.6 versus 1.3, which is statistically significant. But we didn't know if this was due to selection bias, so we probe these further. So for analyzing conversion rate, we compared all the patients, robotic or laparoscopic, put them into one group and compared cohorts based on conversion rate, whether they got converted or not. We found that patients who did get converted were older, were more likely to be male, probably because of a narrow pelvis, more likely to be non-Caucasian, more likely to be uninsured, had a higher comorbidity index, had a higher tumor size, a higher tumor stage, and were less likely to have undergone neoadjuvant chemotherapy or radiation. There was no difference at this point between the types of surgery that they underwent. We then compared the outcomes between those who got converted and not, and we found that most often those who got converted had a unfavorable surgical outcomes, such as a lower R0 section rate, higher hospital length of stay and readmission rate, and a higher mortality rate. We then performed a Cox regression variable, Cox proportional hazards model, controlling for all factors to find out what really predicted conversion rate. We found that male gender, a higher comorbidity index, a larger tumor size greater than 5 centimeters, and a likelihood of getting a positive margin were associated with a higher conversion rate. In the same model, we found that having undergone neoadjuvant therapy, especially chemotherapy, and robotic surgical approach was associated with a lower conversion rate independently. When we did a Cox proportional hazards model for 30-day mortality, we found that just age, sex, and race were independent predictors of 30-day mortality. None of the other demographic variables or the tumor variables or the stage or the therapy ever mattered. And as you can see, whether you got converted or not, or whether you had a laparoscopic or robotic approach or not, did not turn out to be significant in a multivariate analysis when we control for all factors. So what does that mean? This means that in the US, robotic surgery is being increasingly used as an option for rectal cancer surgery. And it is safe, and the outcomes of the patients who underwent a nationwide analysis shows that they have excellent outcomes, and they're comparable to the laparoscopic approach when we compare other surrogate markers like readmission rate or even like margin negative rate. Robotic approach is independently associated with a lower conversion rate compared to the laparoscopic approach. And most importantly, regardless of what approach you choose, conversion of the minimally invasive approach to open surgery was associated with worse surgical outcomes. However, these are not directly due to the approach chosen. So to sum it all up, for rectal cancer surgery, compared to laparoscopic approach, robotic is safe but not safer, is definitely feasible, and is associated with a lower conversion rate, but that lower conversion rate may not necessarily translate into better clinical outcomes. Thank you.
Okay. Any questions from the floor? So again, I go back to, is there any way of looking at the experience of the surgeons, either with the laparoscopic approach or with the robotic approach when you were looking at this?
Yes. We do have the volumes of each center that reported these cases. It is a whole new, that requires another 5 tables. It was outside the scope of the study, but there have been Dr. Berkmeyer's group that have actually used both the national inpatient sample and NCDB, and have shown that the volume really was correlated with the outcomes.
For both?
For
robotic
for
and
all
laparoscopic?
cancer surgeries. They looked at esophagus, colorectal, everything else. So.
Question.
I'm Mazen Al-Mansour from Springfield, Massachusetts. In terms of the methodology, does the National Cancer Database allow you to easily differentiate robotic from laparoscopic cases? Is there any code where you can actually capture these cases appropriately?
Yes. In fact, we chose the National Cancer Database only because this is the only database that we know that specifically attempts to code for that variable. They introduced this code in 2010, which actually says that they code it as laparoscopic or robotic when it is not just a diagnostic laparoscopy or whatever. It has to say that the most definitive part of the operation was done laparoscopically. And then there's another code that says that if that most definitive procedure is converted to open, that's coded as another code. So yes, I think it comes with the problems of any large database, but I think this is the most reasonable database for comparing approaches.
Yes, sir.
Thank you, Eric Dudson from UCLA. It's a very nice talk and a very nice study. I'm not very clever, so I'm going to ask the same question I asked the last speaker, which is, do you think that there may be selection bias in this particular outcome of lower conversion rates, being that the surgeons maybe elected to take on these cases robotically because they had gone past their learning curve in laparoscopy and were comfortable with it, and now they decided they would do it robotically? And they chose patients that were probably easier.
True. Yes, there is selection bias, which is why I had to put the first comparison of the patients. There is definitely differences, but even after controlling for all of those, except, like Dr. Scott said, for surgeon volume, even after controlling for all of that, it is associated with an independently lower conversion rate. Now, for the second question is that, yes, there are robotic surgeons who have chosen because who chose the robot because of their experience. But personally, my personal opinion is that at Roswell Park Cancer Institute, for example, where I'm there, most of the young people who actually do the robot, or even some of the older surgeons, they don't prefer laparoscopy. They actually prefer directly the robot because laparoscopy requires, I think, a visual, motor skill, a different set of skills, which is different from open surgery. But robot is more closer to open surgery than laparoscopy. So I've known at least a dozen surgeons who don't do laparoscopy but do directly robot. So I'm not sure if I can tease that out.
Thank you.
Sure.
Thank you.
Yes, sir.
Yuman Fong from Duarte. Prague, very nice talk and very nice study. I'm convinced that as the cost of laparoscopy and robotics comes closer to one another, these comparisons of robotic versus laparoscopy will kind of be obsolete, okay? And so my question to you, obviously you had access at all the open surgery data, and that's the majority of rectal surgery done in America, okay? Greater than 70% are still done open. How does that compare to these two? And that's because I think the message that minimally invasive rectal surgery is a better operation is the one where you should be trying to test as to whether that actually is the right hypothesis.
Right. That was a fantastic question. There was another surgical group at Duke that worked on the same database as we did, but after we submitted the abstract here, they did compare 3 arms, open, robotic, and laparoscopic, and actually found that laparoscopic is, there's definitely, so let me put it this way, most of the NCDB data and the other data that we look at show a consistent difference in the length of stay only compared to laparoscopic versus open, and it's mostly 1 day. And when we compare, as you said, across timelines, that gap is reducing because even open surgeons are now trying to make a smaller incision and are trying to follow pathways for earlier readmission, for discharging patients. So yes, it is there, and I think there's stuff from the other group that says that overall minimally invasive is better than open, but it's not a huge difference. And one last point about the cost. A lot of people worry about the cost of the robot, but we also looked into cost, not from this database, but for writing this manuscript. It's usually $2,000 to $3,000 difference between the laparoscopic and the robot and the hospital charges. Only $2,000. It's not a whole lot, and most of the cost of the robot is borne by the hospital. It's not really transferred to the patient. Even if it is, it's only $2,000. It's not a whole lot as we think. Yes, there is a cost transfer to the patient, but not a whole lot. So
one more question.
Yes, Steve Rao from Rochester, New York. Another excellent paper this morning that is confirming the clinical outcomes. My question is, are you familiar with or participating in the ROLAR study and David Jane's study out of the UK? And if you have any thoughts, I understand that they are going to present, this is a randomized prospective study, lap versus robotic, that's been going on in worldwide.
Yeah, no, we are eagerly expecting it, but Roswell Park Cancer Institute is not participating in ROLAR. We just have a new faculty surgeon who does routinely robotic rectal resections, but the other ones don't, so we're not participating. But we're expecting that results.
All right. Thank you very much.
Thank you.